So what we're trying to do today is demonstrate in a practical manner the Ponseti Casting Technique for the correction of clubfoot in infants, so that in the future, if they can get them corrected, that deformity corrected now when they're babies, they don't have to have complicated surgeries in the future. Our goal as teachers of the Ponseti technique, from whatever our background, is to teach the local people how to do it themselves for their people, so that they can obviate the need for surgery. So ideal specialists for this are physical therapists, because they have an excellent understanding of the musculoskeletal system, the anatomy, and they're available as very knowledgeable medical personnel. So we try to give them some elementary information, and there's also a website they can go to for much more detailed information on the Ponseti technique as written up by Dr. Ignacio Ponseti.
Okay.
So that being said, we will go on to the practical session. So if you're looking at the deformity in its usual presentation at birth, it's what we call a three-plane deformity. It crosses three planes of the body, the sagittal plane, the transverse plane, and the frontal plane. In other words, this foot crosses three planes in a way it is out of normal position. So what Ponseti said, that if you look at the anatomy of this deformity, the key points, the key anatomical points are this prominence here, which is the lateral talar head, and then the medial side of the foot are the two key points for pressure to reduce the deformity. And if you look at this reduction, meaning making it become more normal, I put one finger on there and I put the other on here, and now the foot starts to resemble more of a normal position. We don't try to reduce this equinus until later. So if we look at the bone structure by itself, the osseous structure of this deformity, the old method of casting was to put your finger here on this calcaneocuboid joint and try to reduce the deformity this way. And if you can see, these 2 points are really not lining up properly. They're not changing, these 2 red dots. And so what Ponseti said is, no, your fingers are in the wrong place. The point of pressure should be here on the talar head where that red dot is. And if you just see with gentle pressure, those 2 dots line up almost perfectly. And to show you we'll show you the other side in a minute. Okay. So we just turn this model around and look at the other part of this deformity. You can see that the heel is angulated relative to the leg. It's turned in like this. If the old method is used to try to straighten it, where you put pressure on the calcaneocuboid joint, there is no change. There's no change in that. It still stays like that. However, if the correct position is used, which is the correct punta or point, it lines up. Watch the heel straighten normally. See, the heel becomes vertical in alignment with the leg. And that is the key point. So these are Ponseti foot models that are correctable and are used for teaching on how to put on the Ponseti cast. So this is the deformity that's usually seen at birth when it's in its maximum deformity. When the cast, what happens here is we put on what's called serial casts, which means we put one cast on, it'll stay on for 1 or 2 weeks, and you do a partial correction of that one. You force the foot over, let the cast harden, and it stays like that for 1 or 2 weeks. Then they come in, you take the cast off, and the next cast is put on, and you get a little more correction with this deformity. And then they come in again 1 or 2 weeks later, take the cast off, put again, and you can see this foot reaching a more corrected position. So after 5 or 6 casts, you can see that there's a correction that occurs. Here's incorrected, Here is a partially corrected foot. When it reaches this position to where we think it's as close to normal as we can, there's one deformity that's left. And if you look at the side, the foot is actually pointed downwards. And that means the Achilles tendon is still tight back here. That is very hard to cast out most of the time. About 80 to 90% of the time then, in order to finish off the correction, that tendon has to be cut. It's a very specific way that it's cut. So that once the tendon is cut, the foot is put into normal position, and then it is cast one more time for 3 to 4 weeks to allow that tendon to heal. And as surprising as it sounds, a tendon that's lengthened up to 1 or 2 or 3 centimeters will heal just fine as long as it's clipped within its tendon sheath. So once that last cast comes off in the corrected position, then the patient must be braced, a special orthosis or brace to hold this position without a cast for this must be used daily or at night on this patient for 1 or 2 or 3 years depending on the response. Otherwise, at least 50% will reoccur and the deformity will come back. Okay, what we're going to do now is a practical exercise to apply the Ponseti cast using Ponseti technique. So first I am going to apply this with, the physical therapist here is Jorge. Jorge Franco is going to hold the model and I will apply the cast. Okay, first you put on a very light layer of padding, and it's important that this cast be applied above the knee all the way to the foot. And the next thing is to start applying the plaster to the leg and the foot first of all, so you can get the correction. After that, the plaster will be extended up to above the knee so that it maintains a better correction and the cast cannot slide off the child. So it's very important to just lay the plaster on as it's rolled on and not pull it on, because you do not want tension which will cause compression or too much pressure on the extremity, on the skin. So when I go around a corner and I have an extra plaster left, I'm actually going to tuck it like this, pull a tuck back to make the corner, and that's what I'm trying to teach him in this position. On English, tuck. So I'm just finishing off at above the knee. The key point while this is drying and getting hard is to get the position of the foot correct, and we leave a little knot on here so that it allows the person taking the cast off to find the cast and unravel it. Now the key point here is to look for the lateral talar head of this bone, and I'm going to put my thumb on that and maintain correction this way by pushing with my other fingers against the big toe side of the foot, just like this. You can see there's a tremendous amount of correction already. Now I must hold that while the cast hardens. And as you can see, I'm not trying to take it out of plantar flexion. I'm letting the foot hang down in equinus. The ideal plaster is to use fast setting plaster, but that's not always available. The key is to be patient and let the plaster harden. So once you feel you have the position in the plaster is hard enough or firm enough, you can take your hands off and then wrap another layer around to get more strength. We will not be doing that today for practical purposes. So in order to help our colleagues, it usually takes 2 rolls of plaster to do one casting. So we try to supply them from our supply to get them started with 2 cases of plaster and some padding. So just to review, what the pressure points are is the head of the talus against the head of the first metatarsal in a very gentle contral pressure. We're working one against the other. very gently but firmly to reduce the deformity, not trying to elevate the foot, but only to push against what we call contralateral pressure, one against the other, firmly, until it hardens. Okay, gracias. So to remove the plaster, we try to have the parents remove the plaster. We try to leave these little knots on there and maybe soak the baby's cast in water. And then once they find this, they can just remove it usually quite easily. A little bit of work at it. It's easier now when it's a little bit wet, but this is what they do, is to remove this plaster. Okay. So now we're going to switch positions here, and Jorge Franco will sit here and I will sit there, and he will now have his turn in a practical education to apply the plaster. These models are very friable. If you move everything too quickly, you'll actually crack and split the models. So we want to use them over and over again. All right. So if you were to look at this, if we started with this deformity here, we would end up with a moderate reduction in the deformity after the cast, like this one. So we're assuming, let's say we've already casted from here to here, now we're going to correct this one a little bit more. And that's the purpose of this next cast. So I'm going to hold for you. So about mid-thigh to start.
Ahora te toca nuestra terapista.
¿Cómo le dicen
Puedes
ellos?
estirar un poquito para que vaya sacando bien.
¿Cómo le dicen ellos a esto?
So we're trying to let him put this initial layer on with just the right amount of firmness. He's doing a very good job of getting it on just right.
Este se llama web reel o algodón, and él está aplicando con un buen técnico. No está jalando super fuerte, pero está rollándolo suave.
So now from here to here is your first layer. Oh, and when you put the plaster in the water, make sure you leave lots of water in it.
Bien mojado.
The plaster has to be very sloppy wet.
Okay.
Cuando está mojándose este yeso, mantenga mucho agua adentro para
Don't go.
ser muy
No,
mojada.
just-
Okay.
No quiere secarlo sin
Medium,
agua en el
medium.
principio.
All right. So you start here and do the foot.
Empezamos abajo la rodilla
Rodilla or knee to foot.
y vamos a bajar al pie.
Que bien estiradito porque no te
Y él va a aplicarlo plano y suave.
Rolladito, desarrolladito, nada más.
Con poco traslapo cada rollo.
Donde
Bien.
quedando pliegues.
Bien, keep going. Bien. If it leaves wrinkles, it's very easy to just smooth out the wrinkles.
Si hay áreas doblados, puede hacerlo suaves con su dedito para prevenir áreas de presión. Bien hecho, muy suave y plano.
Regresa.
Sin demasiada presión. Muestra,
Regresa.
él no está jalando con fuerza.
Okay, continue on.
Sí, ahora para arriba.
I know you
Ahora él va a subir arriba de la rodilla.
Bien.
No usamos
Bien.
yeso de fibra de vidrio, fiberglass. Siempre usamos este tipo porque puede moldarlo, es suave y es bastante mejor. No hay recomendación a usar
Rodilla.
material de fibra de vidrio. es muy difícil
muy
hacer
fuerte
esto
para
Ponseti.
rojillo, okay? Fuerte,
Okay.
fuerte para rojillo.
Terminar,
Bien,
Y
bien.
ahora él está diciendo unido al fin.
Now you make love to the cast.
fijar, echar agua, limpiarlo bien, que no quede pliegues. Y ahora viene el
Smooth the cast down. That's it. Smooth the plaster. Our humor is about what we sometimes say when we're teaching them to smooth the cast, is they say we'd like to tell them to make love to the cast. So, smooth, nice.
El sentido de humor de Dr. Miller no es mi sentido de humor. Es cuando él está enseñando
We'll cut
las
that out.
personas a aplicarlo. Él dice, vamos a hacer amor al yeso. Con sus dedos, espero que no con sus labios.
So, again. So now we're just waiting again for it to harden in the corrected position. You can either use the web of the fingers to do this, or it's correcto, or you can use the thumb to push up against the foot. You're pushing one against the other. We call it contralateral or contra pressure, one against the other, in a very gentle way to reach the more corrected position. Not overcorrection. You don't have to try to get it fully corrected. You're only trying when you get a bit of resistance. You know you're partially correcting it, and that's enough.
Entonces él está empujando en el estrágulo y con presión contralateral del primer metatarsal en una posición transverso, él va a empujar hasta que hay resistencia. No va a doblar el pie o quebrarlo con alta fuerza.
You see he's doing a very good job of holding that position, waiting for the plaster to harden. Again, after he's reached that position and it's hardened, he can put another roll of plaster on, which is very important because babies have strong legs, and it needs to maintain that position for 1 or 2 weeks.
Él está haciendo buen trabajo, con buena posición, muy tranquilo. Y cuando está muy seco, él puede aplicar un otro rollo para prevenir ningún movimiento de nene al dentro este yeso, porque a veces ellos quieren empujar y puede doblar un yeso muy débil y flaca.
We are testing to see how hard the plaster is, and no, it's okay.
más
You
secar.
have to wait.
Cuando ya truena,
But a good way to test it is to just to tap the fingernail on it, or you can feel it with your finger. If you try to release early when the plaster is still soft, the deformity will come back. So it's important to be patient and wait it out.
Entonces, para saber cuando este yeso está muy seco, empújalo un poco, pruébalo un poco para garantizar es bien seco. Si no está bien seco, puede perder su posición y corrección.
Plaster sets as a chemical reaction, and so it's important to wait for that reaction to complete. The plaster will get a little bit warm and a little bit drier, and there already I can feel with my fingernail it's tapping rather than the soft sound.
Este yeso va a secar en una reacción química y va a calentar un poco cuando está secando. No va a quemar nada, pero va a calentar un poco. Recuerda, hay algodón abajo, el piel está bien protegido, pero necesita esperar por esta reacción química a estar terminado.
So, okay, bien.
dale.
So now it's holding. So you can tap it with your finger, feel for ferma, right? Or not ferma, ferma.
Ahora está en buena posición, no va a perder corrección y está duro y puede probarlo y puede oír, está muy seco.
Sí.
Like anything else, with practice, you can do this confidently and dramatically change a deformity in a conservative fashion and prevent surgery often. So training and teaching this technique is reducing an orthopedic deformity without surgery all around the world.